My talk is about an introduction of the technology of drug-eluting balloon, drug-coated balloons, and probably an introduction that because there are another talk that I think there is more deep into the knowledge of these issues that the drug-coated balloon. Okay, so for example, it's first. What are the steps that are for a correct efficiency or efficacy of drug-coated balloon therapy? First of all, is that the technology of the balloon has to be enough good to achieve the lesion, to arrive to the lesion, and could deliver the drug into the vessel. No? So years ago, you have several drug-coated balloons that has very bad navigability, crossability. So the technology is promising, but you cannot treat several lesions, that the technology doesn't arrive to the field. No. So the first is the navigability and the drug retention into the balloon, in the drug-coated balloon, to retain this drug that you want to put into the vessel wall. The second is the inflation of the balloon. It's very important, this inflation, because you have to have the more contact as you can do with the plaque or with the vessel, the arterial wall, because you want to this drug goes from the balloon to the vessel wall. So we have the vessel wall, and this transfer has to be the better as you can, no? Because with that we can have a less dose of paclitaxel or sirolimus or other limus that avoid the toxicity of if you increase the dose on the balloon. And finally, the deflection and retraction of the balloon. At this point, it is very important, the technology that may have the tissue retention of this drug. No, it's very important that the drug that we are delivered to the vessel wall goes into the vessel wall and not goes to the vessel flow to lose this technology. So this is the step that you have take into account to make a drug-coated balloon very well. So there are several factors that can contribute with the efficiency of the drug-coated balloon, of this technology. The lesion, the drug, the excipient, the contact area, the temperature that you have treating the patient, and you can have a reduction of drug-eluting, a dual antiplatelet therapy. So let's go to see one of this. The drug. Probably there is tomorrow there's a talk with Darius Dudek that we can compare the results with the sirolimus with paclitaxel. But remember that there is two different mechanisms for the anti-restenotic therapy for this drug. Remember, limus is cytostatic. They don't kill the cells. They make the cells static and not proliferate. But the paclitaxel is a cytotoxic. It kills the cells. So probably the toxicity can be increased with the paclitaxel in front of sirolimus. The dose of the drug that you put into the technology depends on the technology that you have to transfer this drug to the vessel wall. There are, you can see the excipient, that it will be the next topic that we talk. May have variances of the drug that you put in the balloon. And finally, the chemical properties of the drugs. At this point, the time point that is very important is the lipotropism. The more lipophilic is the drug that you have, the more penetration in the vessel wall. So probably the maximum lipophility is from the paclitaxel. So if you are to build a drug-coated balloon with sirolimus or other limus, you have to have a technology that can help this avoid this less lipotropism than the drug. So what about differences from the different drugs that you have. The most important drugs are sirolimus or paclitaxel. No, so lipophilicity it's less important. It's less marked in the sirolimus. It's highly lipophilic the paclitaxel. The modern action you have talked before is cytostatic the sirolimus, cytotoxic the paclitaxel. The safe margin and the therapeutic range is wide for the sirolimus. It's very difficult to arrive at the toxicity of the limus, and it's very narrow with the paclitaxel. If you increase the dose of paclitaxel, you have problems. For example, in the field of drug-eluting stents, the paclitaxel-eluting stents, that was the Taxus in the first generation of drug-eluting stents, was retired of the market because the toxicity, the formation of aneurysm and the like in the follow-up. No? So the therapeutic range is wide for the sirolimus, narrow for the paclitaxel. The antirestenotic effect is the same for the two drugs. No? They avoid the proliferation of the cells inside the vessel wall and the media area that the vessel wall. And the anti-inflammatory is marked for the sirolimus, but is not there is not anti-inflammatory effect for the paclitaxel. No? So for the transfer to the vessel wall, if we make the encapsulation for the sirolimus or hydrophilic drugs or hydrophilic spacer for paclitaxel. No? And there's important thing for remember the difference of sirolimus and paclitaxel. And it's important to different drugs. For example, there are several trials that compares the sirolimus versus paclitaxel. Probably tomorrow that Dr. Dudek show more detail in that. But in general, that's the idea. The sirolimus is less effective in angiographic terms or point of view. In general, there is less effect anti-restenotic for the sirolimus than they can show in the paclitaxel. The late loss in sirolimus and the magic touch is 0.32, and the late loss for paclitaxel with the sequence please was 0. So the effect of anti-restenotic effect in terms of angiographic results is in general better for paclitaxel eluting balloons. Probably there is another issues that can take into account to decide these results. No? There are several meta-analyses. In general, the effect is the same. In clinical point of view, there is no differences between the two types of drugs, but probably there are studies with a few number of patients, and in general, the angiographic results are better for the paclitaxel. No? There are several meta-analyses. The other is the same. At the clinical point of view, there is no differences between paclitaxel or sirolimus, and angiographic point of view in favor for paclitaxel in front of sirolimus. What about the excipient? There is a lot of formulations that the companies has tested to transfer the drug from the drug coated from the balloon to the vessel wall. There is several drugs that iopramida, urea. There are some nanoparticles that can put the urea for transferring, and in general, let's see the differences and the effects of each excipient. For example, iopramida maximizes the rapid transfer. It helps exactly to move the paclitaxel from the balloon to the vessel wall. It creates a hydrophilic medium and lipophilic drug that push into the vessel wall for the gradient of concentration. No? And the coating dissolves quickly, and large fraction of the drug releases immediately to the vessel wall. So for best rapid delivery, use iopramide. But urea is balances for transfer and stability, because when you have the drug into the vessel wall, I want to the drug keeps into the vessel wall. It is not washed into the vessel lumen. No, so it's a microcrystalline structure that creates with the paclitaxel and reduces the loss during this effect to transfer from the balloon to the vessel wall. So it's controlled and the homogeneous delivery from the more than iopramide. But You can compare, there is a typical comparison, for example, Sequence Please, paclitaxel, 3 micrograms per millimeter, per square millimeter, or Impact Falcon, Iopramid from Aurea, is the same drug, the same dose of drug, but different excipient. And there is a clinical result are the same. So probably all these drugs, all these excipients wants to create this effect, and probably there are two, as the clinical point of view with the numbers of these studies are the same. So probably the two excipients helps to go the drug into the vessel wall. But there are increases in the technology, and for example, the cardionovum restore balloon has the safe pack. The safe pack is the excipient that has in outside the balloon and avoids to create is an homogeneous surface composed with amorphous coating that creates a stable solution of paclitaxel and salt excipient, and the balloon surface coated with powder to brittle crystalline to the vessel to the vessel wall, and to avoid this microcrystalline or distal embolization that they are talking in the talks after that. Okay, and this is a video that shows this distal embolization. No, this you can see on the left the restore balloon, on the right other balloon with paclitaxel, and there's then microparticles that are delivered into the flow that can create this microembolization that can be relevant for the patient at that time. This, for example, comparison of iopramid to safe packs. For example, in the restore in central stenosis China, they compare it's the same dose of paclitaxel, 3 milligrams by a square millimeter, and the only difference is the excipient. And we compare in the central stenosis, and there's the same clinical effect from restore from in front of the Sequence Please. So the efficacy of as the clinical point of view is the same as to excipient. There are another excipients, and they seems to be similar. So the effect of the paclitaxel is quite stable, even with different formulations of the excipient. And then arrives to the technology that are completely different for the sirolimus. For the limus, as you can see, the limus is less hydrophilic, so you have to put another technology to make this transfer to the vessel wall and to keep the drug into the vessel wall. And this is the cell adherent technology, that is the phospholipid and microreservoirs that contains the sirolimus and goes to the vessel wall. As you can see here, the retention of the sirolimus into the vessel wall is 39% of the drug that you put into the balloon, in comparison with the other that is only 5 or 3% of the drug goes to the vessel wall. So for this reason, we have to increase a lot the dose that you put, the drug that you put into the balloon, to reach the same concentration in the vessel wall. So it's a different technology for make this stabilization on the dose. This is more important, the contact area. You have a very extremely good technology, and you are create a lot of technology. You are think a lot how to deliver this drug, but you have to contact the balloon with the vessel wall. If there is no contact, there is no effect of the transfer of the vessel wall. No, so for this reason, it is important that this interface, the transfer from the balloon to the vessel wall, has to be the largest that we can. For to be increased this interface to for deliver for transfer the balloon, you have to select always a 1-to-1 balloon to artery ratio to keep all the balloon to the vessel wall. The temperature, you have to remember that all these technologies are designed, but the maximal efficiency, the maximal gradient from the balloon to the vessel wall are at 37 degrees. So in patients with hypothermia, with other conditions, be careful, because probably there is not the same efficacy than in the regular patient at 37 degrees. The APT, so this is a doubtful situation, because always they say that treating the patient with drug-coated balloon, you can decrease the time of the APT. So my answer is I don't know. There is no trials designed specifically for detecting this answer. So probably you need more trials to detect that is the same effect. 1 month, 15 days. I don't know how many times we need to treat the patient with that and dual antiplatelet therapy. Even for different conditions, the regime of DAPT sometimes not depends on the device that you use into the patient, depends on the clinical syndrome of the patient has. If the patient is admitted by an acute coronary syndrome, by definition, they have to do 12 months and dual antiplatelet therapy for guidelines for the clinical syndrome, but not for the device that you use. It is important for patients that you have to have surgery in the next month, or have the patient that have the bleeding during this time of therapy. It's important to be more comfortable if you have to suspend one of the antiaggregation, no? But we don't know exactly what can have with the APT. And probably the lesion is not the same the lesion that is a fibrotic lesion or non-calcified lesion than other lesion that is completely calcified. I don't know exactly what is the penetration of the drug in this vessel wall. So for this reason, it's very important the treatment, the preparation of the lesion, no? As Dr. Salvatella showed this morning. So it's very important to create some channels to make the diffusion of the drug to the vessel wall. There's a lot of designs of drug-coated and drug-eluting balloons. There is different names from that. And you can see here is not all the drug-coated or drug-eluting balloons are here. That is the majority. And every company wants to have a drug-coated balloon at this moment. Even with a result that I think it's controversial to can go into the market, but in general, this fashion that we have now, and probably we treat more patients with drug-coated balloons. So for this reason, there is a lot of balloons, probably paclitaxel, sirolimus. There are even some designs with paclitaxel and sirolimus in the same balloon to transfer to the patient. So it's crazy the possibility that you have, no? Even with another limus, probably there are balloons with everolimus, and they are testing another balloons. So for conclude, I think the efficacy of drug-coated balloon depends on the multiple factors, not only the drug, not only the excipient. No, there is for example, the drug, it's a type, dose, the properties, and the excipient is and depending the drug, depending the excipient. No, drug-coated balloons with paclitaxel show better performance from the angiographic parameters, but have not yet demonstrated benefit of the clinical point of view. And the excipient may promote the transfer to the drug to the vessel wall, allowing lower concentrations than in the balloon. No? In general, you need a redefined technique must be used in order to increase the deliverability to the vessel wall of the drug, and the vessel preparation is quite important, the balloon sizing in relation to the vessel wall. So this is a special technology. You have to keep the time. It's not in a hurry. You have to prepare the lesion. It's not a direct stenting. You have to prepare and to design. And there are several points that you have to answer to make the same question. Is the preparation so good to treat the patient with the drug-coated balloon with this technology? So there are several points that you have to stop and think, no? During the preparation. It's like the live case that we perform. This complexity to design, and we have to go step by step, preparation, and then showing the result, putting the drug, putting the balloon, and then finish the case. So, okay, thank you very much for your attention.